I'll now go on to our next speaker, Dr. Vishal Govindahari, who is again a Vitreous Retina consultant and also pediatric retinal services from LV Prasad, Hyderabad. And he's going to be talking on many phases of diabetic retinopathy using angiography. And we would have Dr. Guru Prasad as the discussant here.
Yeah, I hope my slides are visible and I'm audible.
Yes, Vishal, go ahead.
So I thank Chitra ma'am and Srinivas sir for this opportunity. Just a small correction, ma'am. I work at Pushpagiri Vitreous Retina Institute, not at LV Prasad, Hyderabad.
Sorry. I'm very sorry.
No issues. So my talk today would be about many phases of diabetic retinopathy using angiography, and I'll be predominantly dealing with FFA and OCTA. So basically, angiography predominantly now has been divided into the use of dye-invasive fluorescent angiography and OCTA, which is non-invasive, dye-free. And there's obviously the new tool in the block, which is not new anymore, which is quite picking up quite quickly, which is the wide field angiography and the ultra-wide field angiography. One sort of definition is based on the number of degrees, while it covers with respect to wide field and ultra-wide field, whereas the consensus statement published by Dr. Sadda and group speaks about the area which it covers. That is up to the vortex mains, it's called wide field, and beyond that, it's called ultra-wide field. So we'll just get to why angiography at all in DR. The main function which we have with regards to angiography in DR, or the phase of DR, which we normally want to assess with the angiography now in today's world, is assessing macular ischemia and prognosticating visual acuity accordingly. Also, assessing the peripheral avascular retina has become a thing of importance, considering the role it plays not just in the development of CNPs and neovascular areas, but also in the role of in recalcitrant DME, the targeted laser techniques which we are using today. Establishing proliferative diabetic retinopathy is something which is less often requiring angiography, and Dr. Tapas has beautifully shown how you don't need angiography, just a red free can do it for you. Detection of some comorbid syndromes like OIS, where the arm to retina time in a dye-based angiography is really useful to sort of understand why a patient is, having sudden neovascularization of iris, for example, just in a case of PDR. We'll look at a few cases to start with. We have a 47-year-old female with a 4-year history of type 2 diabetes with a 6/9 vision in right eye and 6/36 in the left eye. Grading wise, it was just a mild NPDR. The OCT seemed innocuous in the right eye, and the OCTA did have some amount of capillary separation in the deep capillary plexus, which is our main area of interest, because this is the one which supplies the inner retina and causes functional loss when there are changes. But when you look at the left eye OCT, it hardly shows any changes. But you look at the OCTA, there is huge area of avascular zone increase, and these small aneurysms and widening of the intercapillary spaces. This sort of has translated into a lot of ischemia. Traditionally, we would have done a fluorescent angiogram to understand this, but OCTA now has sort of helped us understand this much easier in a non-invasive way. And this sort of helps us, prognosticate and explain to the patient what is happening with him and how we need to sort of work on him systemically. Another case, 44-year-old male, type 2 diabetic with 6/24 vision in the right eye. No improvement further, and a clear lens in mild NPDR. We don't expect a 6/24 vision in these eyes, no CSME. Again, the OCT of the right eye looks very innocuous, barring this single microaneurysm, which my pointer is showing, which is seen in the OCT as well. But when you look at the OCTA, it's quite clearly showing the kind of pruning of the vessel margins with aneurysms and a very, very enlarged FAZ and increased intercapillary space. So this is sort of telling us why the 6/24 is happening here and what we have to sort of work with the patient. So these were two cases where OCTA very clearly diagnosed DMI. Now, clinically, though it is not relevant, a lot of indices which are coming in, like the vessel density or the intercapillary spacing or the fractal dimension, which tells us the complexity of the blood vessels, or the area of the foveal avascular zone, which we are routinely measuring. These are sort of measures which we do on angiography to assess DMI, more on OCTA to be specific. When you look at the significance, vessel density in superficial and deep capillary plexus are quite important for the diagnosis of DM. For DR, as well as just in patients with DM, it's a predictor of oncoming DR. Intercapillary spacing detects CNPs much earlier than vessel density and is much more sensitive. The FAZ area has been a sort of a favorite with all of us with regards to understanding DR severity as well as functional loss. When it comes to the FFA, diabetic macular edema ischemia has been defined as a increase of FAZ more than 1,000 microns, which notched or bordered by microaneurysms, telangiectasias, and pruned arterioles. And this has a direct correlation not only to the functional loss, but also to the severity of DR. Moving on, we look at another case of a 47-year-old male with decent vision, 6'9" and 6'6", 3 years duration of history of type 2 diabetes and hypertension of 1 year duration. Both eyes have early lens changes. Fundus photo did have a few diabetic changes, but the angiogram was quite dramatic. This sort of angiogram we do see quite often. You see large capillary non-perfusion areas in the traditional FFA here. What is important to note is areas of leakage around the vessels. Apart from the NVEs and the CNP areas, you have these late vascular leakage which happens around the vessels. This is basically a sign of ischemia. You can see them in multiple areas along the vessel walls, all along the vessel walls and extending past the vessel walls as well. Notwithstanding the NVEs, these leakages are quite prominent in these eyes. And you have a diffuse leakage at the late face along with an NVD at the posterior. The other eye had some similar findings with large CNP areas, multiple NVEs, and perivascular leakage. So when you look at these eyes, some important things which you have to know is late perivascular leakage is a marker of CNP area and development of further neovascularization. So in a patient who possibly does not have NVEs but is showing a lot of leakage, you would want to sort of look at treating these patients in case you don't have a good follow-up with them or they're not going to have good diabetic control. This intense ischemia was noted in the previous images, and the percentage of ischemia of the total retinal area is defined as the ischemic index. This has a direct bearing on not just the occurrence of DME, but also with the occurrence of recalcitrant DME, with the occurrence of comorbid coexisting macular ischemia and the severity of DR. So these sort of indices are quite useful for us to understand, based on simple angiography, what sort of diabetic phase or diabetic retinopathy phase the patient is in. Very interesting paper by Dhananjay Shukla sir and team, which speaks about featureless retina, where you see in the red fundus photo, and as very nicely shown by Tapas sir, the red free, you find these wiry white arterioles with very minimal findings of diabetic retinopathy and areas of thinned retina. But when you do an FFA, you find quite a lot of CNP areas, you find capillary dropouts, capillary dropouts, you find NVEs, and you find macular ischemia in these cases. So as the description suggests, normally these are eyes where one eye has PDR and the other eye is diagnosed as a mild or moderate NPDR. So it leads to an asymmetric DR grading, but actually ends up being a featureless retina. This is an important finding which angiography can pick up. Whitefield angiography is picking up quite a bit. We have the Whitefield fluorescent angiogram as well as the Whitefield OCT angiogram coming in now. And here we can see that lots of areas which would have been traditionally missed by the traditional 50-degree angiograph, even with a montaging, is being picked up by one shot in the Whitefield. It is expensive and it is a challenge to image with these eyes, but obviously there is purchase with the kind of imaging it comes out. Very interesting fact that compared to 7-field angiography, Whitefield shows 3 times more retinal surface and a multi-fold increase in non-perfusion area and neovascularization. So the detection rates are much higher with Whitefield. Just pardon me, just 1 second. So these were a couple of papers where Mukit et al. Looked at using Whitefield angiography to sort of target their treatment. They looked at a Pascal laser, full threshold laser versus a reduced fluence laser, and they did selective areas of treatment predominantly based on Whitefield, and this led to much better responses with regards to development of reduced development of secondary macular edema or worsening of macular edema, which we can see with traditional laser systems. The regression of PDR was similar with both these systems, and this sort of helped us, to understand that even in these phases of diabetic retinopathy where you do have laser dye, but still there is peripheral ischemia, Whitefield imaging angiography can be very, very useful. To conclude, angiography of any sort, dye or non-dye base, is essential in picking up very subtle presentations of DR, such as macular ischemia and featureless retina. And use of various modalities such as the Whitefield opta help tailoring treatments and prognosticating the various stages of DR. I'd like to acknowledge Dr. Srinivas Joshi and his fellow Rohan for helping me with the images, as well as my fellow Amrita. Thank you so much for the opportunity, and I'm open to any questions or comments.
That was a wonderful presentation, Dr. Vishal. I mean, very, very detailed. And yes, we look forward to the discussion now. Yes, Dr. Guru.
Nice, Dr. Vishal. Thank you for that nice presentation. Just a couple of points, maybe 3 points in all, I have just noted down during your talk. Number one, I'll go from last to first. You said featureless retina. I think one of the cases you showed featureless retina. I just want to share my case. Just about 3 days ago, I had a patient with NVI in a diabetic patient, and I found that the fundus was totally normal. In fact, clinically normal disc, normal vessels, and no, not a single dot hemorrhage or a macroaneurysm, even on 90-day examination or the optos. So I thought we will go for a carotid Doppler test because these patients are, also vulnerable for major artery occlusive disease. So we thought we'll do a carotid Doppler to find out whether NVI is caused by carotid artery occlusive disease. But the carotid turned out to be normal, and then we resorted to FFA. And on FFA, we found that the featureless retina, the so-called featureless retina, was actually studded with multiple leaks right from the disc to the periphery, a lot of CNP areas. So featureless retina is something that you should first investigate with FFA. That was a lesson I learned. Then later carotid Doppler. So this is something which I just wanted to convey. And about the macular ischemia that you mentioned in a patient with 624 with widened avascular, foveal avascular zone. I think they always don't go hand in hand. Sometimes we have good vision in spite of a capillary dropout in the peripheral capillary network. They always don't go hand in hand, and therefore one should also look at the disc, maybe the structural OCT and also the disc in these patients, because they always have some coexisting ischemic optic neuropathy as well. And therefore, we should not just say macular ischemia in all these cases causing the loss of vision. About recalcitrant DME, there was an article by Paul Turnambe long ago. The title of the article was "Macular Edema is a Peripheral Disease." So I think that is something which was very catchy, but I don't know whether we can resort to TRP to control recalcitrant DME. I want to know the experience of the entire panel here. I personally have not had good results with treating or tightening a PRP. We don't have access to more than 102 degrees of angiography, not more than what the Heidelberg can give us. But if wide angle angiography means more than 102, then I think tightening is good enough. Tightening the PRP is good enough to cover up the the untreated areas, and that doesn't really result in treatment or cure of a recalcitrant DME. I just want to know the opinion of the panel. Yeah.
I mean, I agree with you. A very interesting and attractive proposition that peripheral ischemia, if it is more, it gives rise to more VEGF production and macular edema. But I don't think it's ever been proven, although it's a very attractive hypothesis. And we have studies, especially in vein occlusions, where a peripheral ablation has not really changed the macular edema much. So, although it remains an attractive hypothesis, but not really proven. So, I don't really go ahead and do peripheral PRP for recalcitrant macular edema. Either it's diabetic or a vein occlusion. I've stopped doing that.
Right.
Yes, I think I've also had just mixed success. I think when you're talking recalcitrant DME, it's more other factors, non-VEGF factors, which are probably in play rather than burning out everything. So I also agree with Dr. said. I haven't had, but there are anecdotal reports.
But there are cases. Those studies have not shown unequivocally. It has not been shown that peripheral laser is. But there are cases, especially before you shift to a steroid in a phakic clear lens patient. It would be a good idea to do a wide field angio and do a targeted PRP if it shows significant areas of capillary non-perfusion. In such cases, it might help, not in all cases, as Dr. Guruprasad.